to quickly let me know, I don't mind. So I live in Sydney, Australia, and I mostly do see mothers and babies in my specialised clinic, which I really love, but I also do a small amount of general practice or family medicine. And so tonight we'll be talking about medical ethics and specifically autonomy and justice. And obviously I come from, the background of Australia, which I realise might be different to Iraq. So hopefully we can discuss some of those differences tonight too. And sorry, it's tonight where I am, and it's afternoon where you are. So we'll be looking at defining medical ethics, autonomy and justice, and discussing the intersection of autonomy and justice, as well as ethical decision-making, ethical frameworks, effective communication skills, cultural competence, and becoming familiar with those legal and ethical guidelines, as well as the ethic committees and institutional review boards. So to start with, what is medical ethics? So medical ethics refers to the moral principles and values that guide healthcare professionals in making decisions and providing care to patients. And this is important because it fosters trust between healthcare professionals and patients. It maintains the integrity of the medical profession, and it supports the well-being of individuals and society as a whole. So I think it's helpful to go back over the historical context of ethics, particularly in medicine. So it started off with the ancient origins, which was the Hippocratic Oath in the 4th century BC. And that's something that I think you'll probably take as part of your medical school. I took that oath when I finished medical school as well. And that was an early code of ethics for physicians, which emphasized, confidentiality, non-maleficence, which we'll discuss, and patient-centered care. And then in the Middle Ages, the influence of religion became part of it as well. So, those religious institutions started playing a role in shaping medical ethics and emphasizing that care and compassion for the sick. Then, during the Renaissance and the Enlightenment, there was a transition into that evidence-based medicine. And again, that changed the ethical considerations in medical practice. And then it sort of became a lot more detailed in the 19th century. So, medicine became more of a profession. There was this emergence of medical organizations and ethical codes, and there was a big focus on clinical competence and patient welfare. And that was where autonomy really began to become recognized. So we began to recognize the importance of patient rights and consent in their own medical decisions. Then in the 20th century, there were a couple of really important things that happened. So in 1947, the Nuremberg Code was written, and that's a set of ethical guidelines and principles that was established in 1947 as a response to the unethical human experimentation conducted by Nazi physicians during World War II. And these experiments involved horrific abuses and violations of human rights. So the Nuremberg Code outlines key principles that should govern human experimentation, emphasizing the importance of informed consent, voluntary participation of individuals, and the assurance of participant safety and well-being. And this code serves as a foundational document in the field of medical ethics and research ethics, setting standards for the ethical treatment of human subjects in medical and scientific research. Then from 1932 to 1972 in Alabama in the US, there was the Tuskegee syphilis study, and that was a highly unethical medical study which aimed to observe the natural progression of syphilis in the untreated African-American men in rural Alabama, even after effective treatment became available. And participants were not informed of the true nature of the study, and many of them were denied proper treatment for their illness. And this study violated basic ethical principles such as informed consent, beneficence, and respect for participants' rights. It led to significant harm to the participants and their families, contributing to mistrust of medical research within African-American communities. And this study highlighted the critical need for ethical oversight, informed consent, and adherence to human rights and principles in all medical research endeavours. And then after those things happened, bioethics became a discipline in its own right. And that's where we address complex ethical issues posed by medical advancements. So where are we now? Ethics is an ongoing and forever changing thing. And that's because of, globalization. We have medical tourism, access to care is always changing, different cultural norms across countries and within countries. We have the technological advances. So, and again, this is always changing as well, but there's things like genetic engineering, organ transplantation, end-of-life care. Abortion in America is a big thing at the moment as well. And so I think it's important to understand the historical, evolution of medical ethics, because that helps us understand where we are now and where we're going in terms of ethical frameworks in healthcare. So in bioethics or medical ethics, there's the 4 core ethical principles, which we usually use to sort of guide our decision making. And we'll talk about 2 of them in more detail tonight. So autonomy is the first one, and that's respecting a patient's right to make informed decisions about their own care and treatment. An example of this would be ensuring that patients have complete information about treatment options and involving them in the decision-making process. The next one is beneficence, and that's acting in the best interest of the patient and striving to do good and promote well-being. And an example of that is prescribing the most effective treatment to improve a patient's health and quality of life. The third one is non-maleficence, and that's avoiding harm and minimizing risks to patients and prioritizing their safety. And an example of that would be choosing a less invasive procedure when the potential risks of a more invasive option outweigh the benefits. And then there's justice. And that's, fair and equitable distribution of healthcare resources, treatment and opportunities. And an example of that is allocating limited healthcare resources based on medical need rather than social economic status. So in terms of applying these 4 principles, this 4 principles approach helps us as healthcare professionals to consider multiple ethical perspectives and make decisions that align with fundamental principles, ultimately promoting ethical care and respectful treatment of patients. So the first step is to identify the ethical issue or dilemma. Then we evaluate the situation using those 4 principles, and we consider how each principle applies and might conflict with that situation. We weigh the principles against each other and prioritize them according to the specific context. And we develop a course of action that best balances the principles and respects the values and rights of all parties involved. So going into a bit more detail with autonomy, autonomy in medical ethics refers to that principle that individuals have the right to make decisions about their own healthcare and medical treatments. It emphasizes respecting patients' self-determination and their ability to make informed choices based on their values, beliefs, and preferences. Healthcare professionals should provide relevant information, ensure comprehension, and obtain voluntary consent from patients before any medical intervention. And autonomy respects patients' rights to accept or refuse treatments, even if their decisions differ from medical recommendations. And it's a fundamental principle that promotes patient-centered care, upholds individual dignity, and recognises the importance of patient agency in medical decision-making. It's important because it empowers the patient to actively participate in their own healthcare and promotes that sense of control and involvement. It upholds that fundamental right to self-determination and respects the inherent dignity of every patient. And it also fosters that collaborative relationship between the patient and the healthcare provider, which leads to more personalised and effective treatments. The challenges with autonomy is that sometimes we have to balance autonomy and beneficence. So that is to do good. So, we have to navigate situations where a patient's choice may conflict with medical recommendations for their well-being. And, an example of that is that, there might be a patient who's refusing life-saving treatment. So you have to address that situation where a competent patient rejects a treatment that could save their life. And that's that, beneficence where that you can save their life to do good by them, but the autonomy of that patient making a choice for their own life and their own health. And other challenges are the cognitive limitations. So we need to make sure that patients have the capacity to understand complex medical information, especially in critical or end-of-life situations. And autonomy respects the patient's right to self-governance and allows them to make decisions that align with their values while promoting their overall well-being. So the next principle is justice. And justice in medical ethics refers to the fair and equitable distribution of healthcare resources, treatment, and opportunities among individuals and populations. And this is about being fair, so ensuring equal access to medical care and services regardless of your financial background, ethnicity, gender, or other factors. It's also about addressing health disparities. So by providing additional resources to, communities that are needing additional help in order to get that level playing field between communities and populations. And then also advocating for the vulnerable populations. So making sure that the rights and the well-being of marginalised groups who may face barriers to healthcare are considered and, included. And this is, again, important because it ensures equal treatment and it helps to prevent discrimination and ensures that medical care is distributed based on medical need rather than social advantage. It upholds justice and trust in the healthcare system, and it addresses concerns about biased or preferential treatment. And it also promotes the overall health of communities by addressing those systemic inequalities that affect health outcomes. In terms of challenges, there's always a couple. So resource allocation is an ongoing challenge in ethics, and that's because we have to prioritise limited, resources, such as organs for transplantation or critical care beds during a pandemic. And that has really become relevant in the last couple of years with COVID, deciding how to distribute that life-saving supply of medication during a public health crisis, or, in that case, deciding who gets the ICU bed when you have 10 people who are sick and, 2 beds available. How do you choose who goes into those beds? And then there's also the balancing of individual and community needs. So we need to weigh up the needs of the individual patient against the health needs of the broader population. And so then there's the intersection of autonomy and justice. So where these two principles, meet one another and sometimes conflict. So we'll consider a scenario where there's 2 patients, patient A and patient B, and both are in critical need of an organ transplant, but there's only one available organ. So in terms of autonomy, patient A and patient B both have the autonomy, so that ability to make the decision about their own healthcare. And patient A, who is in dire need of an organ, decides to refuse the transplant due to personal beliefs or fears about the procedure. Patient B, while also in need, is eager to receive the transplant and improve their quality of life. So if you just look at autonomy, then it seems quite clear that patient B should be the person who gets the organ. But then if you consider justice, the principle of justice requires that available organ is allocated in a fair and equitable manner. So it involves not only the consideration of autonomy of the patient, but also the overall welfare of the population. So it could be that patient B, if they didn't have the transplant, would live for 15 more years, but patient A without the transplant might only live for 1 more year. So, if you're looking at it from that sense, it would be more beneficial to give the organ to patient A because they're more in dire need of that organ. And so it's about evaluating that medical urgency, the potential for successful transplantation, and also the potential impact on each patient's life. And so the challenge is to balance that autonomy of patient A's decision to refuse the transplant with the goal of maximising overall well-being and equitable distribution of resources. So the medical team has to navigate respecting that autonomy, but also considering the just allocation of that organ to ensure that it benefits the individual and the community at large. And there is no clear answer. There is no one correct answer. But, medical professionals guided by the principles of autonomy and justice can engage in open communication with both patients. They may involve ethicists or review boards, which we'll talk about later, to carefully assess that situation. And while respecting patient A's autonomy, they also need to consider the urgency of patient B's need and the ethical obligation to allocate the organ to the person who will likely benefit the most. So as you can see, there's an intricate balance between respecting that individual autonomy and ensuring justice in that allocation of a limited resource. And it's, they're complex decisions that healthcare professionals have to make. And we always, want to and are trying to achieve a morally sound outcome. So ethical decision-making, involves that systematic navigation of complex moral dilemmas to determine the most appropriate or the best course of action according to those principles. So the first step is to identify the issue, so recognizing the ethical dilemma and the conflicting values or interests involved. Then we gather information, so we get all of the facts, the medical information, the perspectives from patients or communities that we need to. And we're going to identify the ethical principles, so those 4 that we've talked about, beneficence, non-maleficence, autonomy, and justice. And we look at each principle and how it relates to that situation. And then we consider options of potential courses of action, and we consider what the outcomes would be in both the short and long term, depending on which decision that we make. We can evaluate consequences, so we assess the potential impact of each option, on the patients, the community, the healthcare system. And then we make and implement that decision based on what we have decided is the best way forward. And then at the end of it, we can reflect and learn. So, we can evaluate how that decision went, what were the outcomes, and reflect on that decision-making process to improve our future judgments. And I think ethics is something that's always changing, even in, the smaller, like not so obvious situations. Your own practice will change over time. I will see things differently now to how I did, 10 years ago. And that's okay. And that's a really normal part of, growing as a medical practitioner. So factors that influence ethical decisions, there's our medical knowledge. So we have to have an accurate understanding of medical facts and treatment options. Cultural and religious values are really important. So we need to consider not only our patients' diverse beliefs, but also our own, and think about whether we're perhaps bringing our own religious or cultural values into the decision about somebody else. Then there's the legal and institutional guidelines. So there's adherence to laws, regulations, there's professional codes of conduct that we all have to follow. And then there's a stakeholder collaboration. And what I mean by that is the involvement of patients, families, colleagues, ethics communities, other people aside from the specific patient. And then we have to also consider the challenges. So we're balancing those conflicting principles, and sometimes, if you just look at one principle, it's a really clear decision. But if you look at another one, then it's not so clear. Often things are uncertain. We don't have all of the information. We don't really know what the outcome's going to be. And there is no one right way forward. And then there's the resource limitation. So if we have scarce resources, how do we distribute those in a way that's fair and just for everybody? And so some ethical dilemmas in healthcare, there's, as we've mentioned, they're allocating limited resources. End-of-life decision-making is always grey, and people see that differently. There's informed consent and competence, so knowing that people are able to make decisions for themselves and, understand the potential outcomes of their decisions. Confidentiality and privacy of patient information. And then there's cultural and religious considerations. And just a couple of quick examples. So in Australia at the moment, we have a couple of states that do euthanasia or assisted suicide. And what that means is when the patient is able or decided that they don't want to live anymore, or that they have a life-limiting illness that can't be cured, they can choose to end their own life in some parts of Australia. And that's a really tricky thing, because you're balancing that patient autonomy, that patient's decision to choose, as well as the societal values of how we feel about, ending life, prematurely, and also the medical responsibilities of the doctors who choose to look after those patients. Then there's things like genetic manipulation, and that will, become more and more over time. Sorry, I just saw something. Yeah. And so an example of that is, as we get further and further, advancements of reproductive technology, like how far can we manipulate those genetics to, choose outcomes for patients, and, how much can humans intervene in that? And it's grey. And then there's medical research. So we need to ensure that ethical treatment of human subjects is always a high priority and that our results are accurate, so you can't forge medical results, research results to get specific medical outcomes. Beginning and ending of life is always a difficult and, sometimes controversial topic. And, as an example, in termination of pregnancy, there's the religious views of the doctor, there's the religious views of the patient, there's the laws of the country that you live in, there's the reasons which it may proceed. So, is it okay to choose the gender of your child or to terminate if you don't like the gender of the child? And is it then okay only to do it, for example, if the baby is, has medical reasons and wouldn't survive past birth anyway? So how do you decide? How do you decide when you terminate a pregnancy and when is it okay to terminate a pregnancy? And that will be different for different people and different laws as well. So there's lots of things that you're juggling. Organ transplantation is another big one. So in Australia, we do organ transplantation, but many people die waiting for an organ. And when an organ does become available, how do we choose who to give it to? And then obviously euthanasia, as I mentioned as well. So how do we decide who's eligible? How do we decide who's eligible, who can perform it? How do you assess things like coercion of the patient, mental illness of the patient? How long is somebody likely to live? There's lots of questions and there's no clear answers. And then there's the emerging issues in medical ethics. So things like genetic manipulation and testing, telemedicine and remote patient care. And that's quite a big thing in Australia because our country is huge and there's often people who live hundreds or thousands of kilometres from healthcare. So we like to be able to, provide medical care for these patients, but how do we do that in a way that is safe and effective for them? And then also artificial intelligence and decision-making is becoming a big problem. So, or, not a problem necessarily, it's a great thing too, but, how do we balance that artificial intelligence with good decision-making for patients? So moving on a little bit to effective communication skills, there's the informed consent. So we need to clearly explain treatment options, benefits, risks, and potential outcomes to patients. We need to make sure that we're using language that patients and families can understand. So not big medical words, but just simple language where they know what you're talking about. And we have to make sure that we give lots of time for questions and ensuring the patient's understanding before we, get them to consent to a procedure or medical, intervention. It's really important to respect autonomy. So we need to encourage that open communication and active patient participation in decision-making. It's really important that the person who is the patient understands their illness and their diagnosis and that's not hidden from them. And that's, really important because everybody has a right to their own health information. And it's, we need to be able to include that person in their decision-making. We need to listen actively to patients' concerns and values and preferences and incorporate their input into their own care plans, even if it's not, what we would do if it was our own health. Then we need to be able to deliver difficult news. So we need to choose that appropriate setting, create the right environment, use that empathetic language and be sensitive to those emotional reactions and offer emotional support and provide resources for coping. And this is all, easy to talk about on paper, but obviously when you're, busy and you're in a hospital and you have a lot of people waiting, it's very hard to sit down and take that time to spend with people to make sure that they understand and, can talk about how they're feeling as well. Conflict resolution is really important. So we need to be able to address conflicts openly and respectfully. Active listening, so that we can understand the perspectives of the other people who are talking and who are involved. And it's really important to focus on those shared goals, of the patient well-being when we're addressing disagreements. End-of-life conversations are particularly difficult, so we need to initiate those conversations early. In Australia, we have something called the Advanced Care Directive, and some patients will do this well ahead of time, and it's a legal document that actually explains in detail what they would like to happen to them when they reach the end of their life, or when they're no longer able to make decisions for themselves. So, for example, it can be very specific. It can say things like, if my heart was to stop beating, I don't want to have chest compressions, or whatever. So we need to have those conversations, put plans in place when patients are able to talk about it, so that when these things happen, we sort of know what their concerns, their fears, and their hopes are. And then sometimes we need to provide information about, palliative care, so end-of-life options, and help patients make, informed decisions about their care. Cultural sensitivity is really important. We need to respect those cultural differences in communication styles and beliefs. In Australia, this is a really big thing because we're a very, very multicultural country. And so, I might have my own understanding of, what I would do in that situation, but that might be very different to somebody else, to the patient who's in the situation. So it's really about acknowledging and noticing our differences and, trying to put them aside to be sensitive to the person that you're looking after. And sometimes we need to adopt our communication approach to accommodate that patient's cultural background. And we also need to recognize and address those misunderstandings that arise from cultural differences. Maintaining confidentiality is really, really important. So, we can explain those principles to patients, and, we can say, like, whatever we talk about here is, staying within this room, so that they have that trust to, talk to us about their medical situation. We have to tell patients who we will give medical information to and under what circumstances, and address concerns about sharing medical information with family members. So the person may be willing to tell you about their medical history, but they might want to make it clear that they don't want their family to know. And that's where you can be really clear about what you will and won't share with others. And often I'll see, because I work in a mother and baby clinic, like I'll see, mothers, and they, don't want their partner to know something, but they want to tell me something. So it might be about their past, or about, a medical condition that their husband doesn't know about, or something. And it's really important to protect their privacy, even though that might not be what you do. You might want to tell your own partner, but if that patient chooses not to, we have to respect that decision. Shared decision-making is really important as well. So we need to present those treatment options, the benefits and the risks, and then talk about, the good and the bad with the patients based on their own values, to make decisions that align with their own preferences. And then we obviously need to document whatever we talk about. So whatever decision you've made, or risks and benefits you've discussed, make sure that you document those in the record, the patient record. So in terms of cultural competence, in medical ethics, this is about understanding, respecting, and effectively addressing the diverse cultural backgrounds, beliefs, and practices of patients and their families in healthcare settings. This is really important as it upholds that principles of autonomy, beneficence, and non-maleficence by respecting that patient's cultural autonomy. It reduces the disparities. So, it allows that more equitable treatment for all patients. And it builds patients' trust, rapport, and effective patient-provider relationships. It's important to know the cultural norms of the area that you're in, and learning about different cultural values, communication styles, and healthcare beliefs is really important. And it's also about respecting diversity. So, knowing that people come from really diverse backgrounds, and being respectful of that, even if it's different to, the way that you would manage a situation. And an example of that is, again, this is an Australian example, but there's a religion called Jehovah's Witness, which you may be familiar with. And in that religion, they are not allowed to accept blood transfusions. So in Australia, if they were to have a medical procedure, they'll have a very clear documentation that they cannot receive a blood transfusion under any circumstance, and will, almost always willingly die over accepting a blood transfusion that could save their life. And so even though this is different to, what I would do in that same situation, it's really about addressing that patient's refusal based on religious beliefs, and upholding their own decision to make the decision that is right for them. So in legal and ethical guidelines, that's another thing that we have to balance. So the legal guidelines provide a framework for the minimum acceptable standards of conduct. And those ethical guidelines, those 4 principles, they offer a broader perspective. So they emphasize values, principles and moral obligations. And this is important because it ensures patient safety and respect and well-being. It supports that trust between patients and healthcare professionals, and it upholds the integrity of the medical profession and the broader healthcare system. And an example of that, might be, coming back to termination of pregnancy, it might be that legally, it's allowed in Australia. So in most places now, termination of pregnancy is legally allowed, but in certain hospitals, so for example, there's Catholic hospitals that are obviously and understandably pro-life, so they don't offer terminations in their hospitals. And so it's balancing, the legal rules of the country with the ethical sort of, principles of the services offering, different medical procedures. And sometimes it is a tricky balance to get it right and to look after the patient. So there's the legal considerations, and an example that we'll use here is the ethical decision making for minors, so for people who are under 18 years of age. In most areas, minors who are under the age of 18 are legally considered incapable of giving consent for medical treatment without their parental or guardian approval. And sometimes healthcare providers may face legal repercussions if they provide medical care to a minor without proper parental consent, especially for certain procedures or treatments. But then if we look at the ethical considerations, we need to respect that principle of autonomy, even when we're dealing with minors. So older adolescents, so say from about 14 to 18 years of age, usually have the capacity to make, informed decisions and to understand their own healthcare. And the dilemma might arise whether the 14-year-old's autonomy conflicts with that legal requirement for parental consent. And that's particularly in situations where the minor or the child, seeks sensitive care, like reproductive health or mental health treatment. So, for example, if, a 15-year-old wanted to come in and start contraception for, to prevent pregnancy, it's difficult because they may not want to tell their, parent, but technically, do they need parental consent? And where does it happen between, the problem of autonomy of that patient, but also the legal need for parental consent? And sometimes that's difficult to navigate. We sort of need both of those. And in Australia, we have kind of navigated that in a sense by something that's called GILIC's competency. And that means that if a child is over 14 years of age, and if they're able to understand the risks and benefits of their treatment, then they can generally consent for treatment without their parents' consent. But the important thing about that rule in Australia is that they can't refuse treatment. So they can consent to treatment. They could consent to an operation if they need it. But if it was a life-saving operation, they actually can't refuse that treatment until they're 18 years of age, or unless their parent consents. And in Australia, that's how we've gotten around that kind of dilemma between the older child, and what they can and can't do. So the last thing to sort of touch on is the ethics review committees and the institutional review boards. And ethics review committees are independent groups that are responsible for evaluating ethical aspects of research that involve human subjects. And this is about having good research protocols and ensuring that they align with those 4 ethical standards, and most importantly, that they protect the participants' rights and well-being. And then there's the institutional review boards. And that's a type of ethics review committee that specifically focus on medical and clinical research. And they operate within hospitals, institutions, universities, and research organisations. And there's a number of people on those boards. So there's healthcare professionals, ethicists, legal experts, and community representatives. And those boards meet usually every month or so, and they review, approve, monitor, and oversee research involving human participants. So in Australia, all research projects have to be approved by an ethics committee. And it's also, if you wanted to make any change to your project, you need to go back to that ethics committee and make sure that they approve. So it's really strictly monitored in Australia and probably in Iraq as well. I'm just not so familiar with the Iraqi system, but we have these really kind of stringent boards in place to make sure that participants are kept safe during any research. And the good things about that is that it ensures that research protocols are ethical, and that those 4 principles, so the autonomy, beneficence, non-maleficence, and justice, are all considered. It protects participants, so we look at the potential risks to participants, and we measure that risk to mitigate or to reduce kind of the risk of harm to patients. They make sure that there's informed consent, so that anybody who is participating in research understands the process, and they have information and ability to make a choice to enter the research or not. They also look at study design. So study design is obviously really important. And then they make sure that patients are being recruited in a way that they aren't, being influenced or coerced to sort of participate in research in order to, achieve or to receive treatment. And then they have an ongoing monitoring system. So they oversee research progress, and they make sure that there's ongoing participant safety. And this is really important because it ensures that research is conducted ethically, and that it respects participants' rights. It provides an objective and critical review of research protocols, and it upholds public trust in the research process, and it contributes to scientific validity. And an example of this is where, there's the benefits of conducting potentially life-saving clinical trials with that ethical obligation to minimize the risks and protect vulnerable participants. And that was all that I had down for tonight. I'm sorry, it's a lot of information in a short period. So I'm happy for any questions, or if you wanted to email or reach out, you're welcome to, and that's my email address there.
Thank you very much, Dr. Melody. This is Adnan. How are you?
I'm good, thank you. How are you?
Thank you very much for your time and for your nice presentation and excellent expression and sharing of your knowledge with your colleague in Iraq, Al-Ayen Medical College, and your student. Actually, it was very interesting subject, and we need more. We are seeking for more serious. It's a big subject and complex. And anywhere in the world, as you mentioned, there is different in the culture, there is different in the laws, and different in the habits of the patient, how to deal with them, how to explain the disease to them, and what are the law, and what are the institute you're working with it. And you have a team, multidisciplinary team. I have a question for you, actually. In most challenges we face in our country, you covered in these lectures. It is the same, but one of the big challenges is that you mentioned is the knowledge of the patient, how to explain the medical knowledge of the patient and the doctor. I think it should be delivered by a multidisciplinary teams, or as you mentioned, ethical review board or institute committee. This will deal or challenge or solve this challenge. The second thing I want to ask you about, what if you face the patient with cognitive impairment? Who take the decision? Suppose that she has a breast cancer and so on. Who will take the decision? Is the family authorized in Australia or other things, or according to the guideline, according to each country? And thank you if I hear from you.
Yeah, thank you. That's a really good question. So there's a couple of things. There's something that I mentioned, that advanced care directive. So that's a legal document that we can do at any point. So if you did it when you were mentally competent, and then you become incompetent later from cognitive impairment, those guidelines that you said will stand. So you may have said that you're happy to have you know, chemotherapy or whatever it was. So if that document exists, which often it doesn't, but if it does, that can guide the decisions. Otherwise, you know, we talk to the family and the, you know, caregivers of that patient. And then if there is no kind of clear, correct answer, we have what's called guardianship boards, and that is like basically an ethical review board that the case is taken to, and the doctor and the patient's family can all attend and decide what to do. And then ultimately the board makes the decision, but they will consider every person's case, the doctor, you know, the caregivers, the patient, and then decide what would be the best thing to do. But it does get difficult because often, you know, it's actually quite time urgent to start treating a particular illness, but you need to wait sometimes for that ethics board to make the decision if there's conflict between the medical team and the family and there's no legal document in place to tell you what to do.
Thank you very much. Thank you very much. And we hope to see you in Nasriya, you and Imad together.
That would be lovely.
Thank you, Adnan. This is Imad. Just to add on to your, I have an example. As you know, I'm a gynecologist. So I have a mother who came with her daughter to my practice. That was about 15 years ago. And she has severe cerebral palsy. So she's wheelchair bound. So the problem, she has very heavy menstrual bleeding. So the mom is not coping with the daughter's periods, you know, menstruation. So she asked me to do hysterectomy on her daughter or do something because she can't control the periods. She has very bad bleeding and the mom is not able to carry the daughter and clean her. So that's an example that I did not have. Even the mother is asking. I have to go to the guardianship board. Guardianship board, as Melody mentioned, it's a legal institution. When there's a difficult decision to be made, they will agree. So I write application to them. I said, this mother wants hysterectomy for her daughter, but the daughter is only 21 years old with severe disability. And they studied the case. And 1 week later, they returned the answer to me. They said, go ahead, you can do the hysterectomy. So I just wanted to give my example in that regard.
Thank you very much, Dr. Imad. Actually, good example, because as you mentioned, so you are encouraging us in each institute to establish a committee or legal board who make the decision, and he will help to solve these challenges.
Takes the responsibility of the parents,
yes,
the family, and of the doctor in the situation like this.
That's right.
I can see that somebody's raised their hand.
Yeah, hi, this is Hadi Al-Sagar from the Medical School and Al-Ayen Medical School. I have a question. I think it might be like on behalf of the students or even the teaching curriculum. So at which level the medical school in Australia give this topic to the students, the ethic? Is it a class? Is it like a module class for the students, or is it like a lecture, or is it one presentation for the, let's say, in term for teaching the student, you know, some details about the ethical of issues in medical, like hospitals and so on, and which levels you guys like give it for the students?
Yeah. Thanks. It's a good question. It does start, so in medical school here, it's mostly a 4-year degree, and it starts in first year. So we talk about it, you know, like we are now, just those early principles, and then you sort of build on knowledge. And as you have cases that come up, you know, during your clinical experience, it's really great to come back to, you know, these ethical kind of discussions and talk about things you saw and, you know, what you thought was done well or what you thought should have been done differently. So that happened for us. We learn about the principles early on in the degree, and then we build on that learning throughout as we, you know, get more and more complex kind of cases come up.
I think in the Iqara school, same like 4th year students, which is like we call it akhlaq al-tibbiyya in medical school, you know, which means ethical. What about? So I have another question. What about the module? Is it like the student have to have exam in it? Because previously I have like conversation with one of my colleagues, Dr. Adnan, know him, Dr. Ali Naif. He mentioned that the ethic classes shouldn't be based on exams, because it should be based on like, it's like a teaching class, learning class without exams. So the students, they're gonna learn without any pressure from the passing this exam or not passing. Yeah. So what do you think about this? Is this gonna be, should be based on exams or just extra information, let's say? What do you think?
Yeah, I think it's probably important to have both. So the exams, I guess test the knowledge of whether you know the principles and understand what they mean. But then discussions, just like this now, you can have a group get together and talk about cases, because there is often no correct answer, so you can't put on an exam because there is no one correct answer. But to have discussions with colleagues and, look at all of these different aspects often just helps clarify your position on things.
Thank you so much. All my greetings for Dr. Adnan, Dr. Ahmad, all my colleagues. By the way, I'm not in Iraq now, I'm in the UK, so that's why I gotta just say hi for everyone and to all my students. Thank you so much.
Thank you, Hadi, very much. Thank you very much, Habibi.
Thank you, Dr. Bye.
Any question from the student, from Dr. Amar, our colleagues?
Nawar,
Yeah.
Nawar Al-Attar.
Nawar, yes, Nawar Hisham from Scotland.
Yeah, thank you. First of all,
he is my friend and my brother, my colleague, at the same graduation with Imad and me from Mosul University. Dr. Nawar Hisham, he is a well-known cardiac surgeon in UK, in Glasgow. Welcome, Dr. Nawar Habibi.
Thank you very much. Thank you. I'm grateful for this opportunity, and it's a real pleasure to meet with friends after so many years. And Dr. Jackson, thank you very much for your presentation. I have a comment following Heidi's question. Then I have a question for you, if you don't mind. So I am, as our dean, Dr. Adnan has just mentioned, I am affiliated with the University of Glasgow here in Scotland, and part of our admission to medical school for MBCHB students is to have a scenario which often is related to medical ethics. So your talk today would be very relevant for any student before they get into medical school. In fact, it's part and parcel of how we evaluate them and the interviews that they undertake before they're admitted to medical school. And of course, as a young doctor, this is part of good medical practice, and the GMC would request and require that these practices are adhered to in the professional life. So I just wanted to add that it's not just part of the medical curriculum, but in fact, it's something we expect students applying for medical school to be aware of. And beyond that, my question to you is, in your slides, you were talking about patient-centered care. There's great emphasis on person-centered care, and the person here is a wider definition of not only the patient, but also the entourage, the family, the next of kin, and so forth. I wonder what your thoughts were around that, particularly as a GP, where I suppose your contact with the patient and the family is more extensive. And thank you again. That was a brilliant talk.
Thank you. Yeah, that's very true. And I think all of us, we are, as humans, we're community-minded people. None of us really operate alone. So it is difficult, to balance those. And I think, I guess what I often do, and I work in a bit of a specialized area of mothers and babies, and often a lot of mental health problems, because they're in that early postnatal period. But I will always pretty well see the mum with the partner if she brings them to the appointment. But I'll often actually get the partner to leave for a little while and have a talk to her privately, because things might come up, separately that she's not willing to see, just to speak about as part of the kind of consult. So it might be things like, a past history of mental illness, or a past history of abuse or domestic violence, or concerns about her own mental health that she won't talk about in front of her family, but it is really important to her care. So I think it's helpful to sort of see the patient both by themselves, wherever possible, but also with their support person or support people, because it helps you get a better picture of that whole the whole picture rather than just one aspect of it. And like you said, there's no one kind of way that is gives us all of the information. So it's about being really flexible about how we can get more information. And also sometimes what I'll do is I'll actually try to talk to the family without the patient. So I might even, as an example, like ask the patient to do a urine test, and they'll take the urine jar to the toilet, and that gives me 5 minutes with the family without the patient to try to get some information that way. So yeah, it's a big picture, and can sometimes, you know, take time and effort to piece together all of those bits of information to make good decisions for that patient.
Thank you.
And also what you mentioned earlier, in my medical school interview, I had a question about organ transplantation and who would you give the organ to as well. So definitely it's relevant from very early on.
Okay, great. I think we've got no more questions here. Nobody is raising their hand. So yeah, Dr. Melody Jackson, thank you very much. As head of the medical education unit at Al-Ayen Medical School, I'm so pleased, or we are so pleased to have you here. Thank you very much for sharing such like an important knowledge with us. And yeah, thank you very much. And thanks to Dr. Adnan Ta'an, the head of the medical, the dean for the medical school, and for Dr. Imad. It's both hi and bye. I'm so glad to see you here, Dr. Imad.
Yeah. Hi, Omar. How are you?
Thank you very much.
Good
Thanks to everybody. Thank you,
عماد
Dr.
انت
Melody.
اشكر نوار. عماد انت اشكر نوار نيابة عني، يعني اكيد يعني.
Thank you, نوار. وين نوار؟ ما اتذكر يا نوار.
نوار هشام العطار. نوار هشام العطار.
Yeah, I remember Anwar. Because there was 2 or 3 Nawars in our
مثل عماد عندنا ايش قد كم عماد يعني كان.
Yeah, we had 5 Imads. Yeah.
Thank you very much, Dr. Nawar, for your attendance, and actually we hope to meet together in a short time.
I look forward to that. I look forward to you visiting us as well, Adnan. You promised me that visit, and Glasgow awaits you.
Thank you very much, Habibi, Dr. Nawar. Thank you, Melody, for your nice presentation and your time. Thank you, Imad. Thank you, all attendants.
Thank you all.
And we hope to see you in Al-Ayen and Nasiriyah. Thank you very much.
Inshallah. Thank you very much. Bye-bye.
Bye-bye.
Bye.